Hi, everybody. This is Mary Ann Cooney. I'm the Chief of Health Systems Transformation at ASTO, and I'm welcoming you all to the Integration Forum All Partner Call. And first of all, I want to give a shout out to anyone who's having a really good view of the solar eclipse today. I believe that when we made the arrangements for this webinar, we didn't anticipate that it would be such a hot day to see the brilliance of nature in its best. But I'd like to welcome you all, and we have a panel of distinguished guests today who will join us to talk about alternative payment models that drive the value in care coordination in federally qualified health centers and rural health clinics. The panel will be followed by a group discussion, and you will be given instructions about muting your lines, and the operator will open them for the discussion following each speaker. You may also submit questions by using the chat box that's located on your screen. Last, the call is being recorded, and presentation slides and a meeting summary will be posted on ASTO's website and shared in the next Integration Forum newsletter. We'll hear first from Rachel Yalowich, Policy Director at the National Academy for State Health Policy, or NASHP, who oversaw an academy for states to develop these models. She will turn it over to her partners in Oklahoma, Adrienne Rowland, who is the interim director for the Center of Health Innovation and Effectiveness at the Oklahoma State Department of Health, as well as Cassidy Height, Public Policy and Communication Associate at the Oklahoma Primary Care Association. Pardon me. So I'd like to first introduce Rachel. Thank you for joining us, and you can take it away from here.
Great. Thank you, everyone, and thank you so much for having me today. I am with the National Academy for State Health Policy, and we have been working with states on federally qualified health centers transformation into value-based purchasing models for a couple of years now, and so I'm very excited to be with you today to share our work. So a little bit about who I work for. The National Academy for State Health Policy is a nonprofit, nonpartisan organization, and our mission is to work with states across branches and agencies of government to advance, accelerate, and implement policy solutions to challenging healthcare issues that we face today. And so I'll start a little bit broader than FQHC delivery system and payment reform, and thinking about why we're talking about value-based payment. And the reason why we are focused on that here at NASHP is because we see that volume-based payment models are not really supporting providers in delivering care that achieves the triple aim, improved health outcomes and patient experiences, and reduce costs. And so thinking about how we can develop payment models and at NASHP support states to develop payment models, working with providers so that they can achieve those goals. Today, you will be focusing on, mostly at the primary care level of the delivery system, focusing on FQHCs. FQHCs are a really interesting provider group to think about in terms of value-based payment. Many of them have been engaged in patient-centered medical home work for a number of years now, either through participation in Medicaid state initiatives, and also they've had a lot of grant funding from HRSA to support primary care transformation. So so many FQHCs are really advanced and excellent providers of comprehensive, coordinated, and patient-centered care. And so thinking about how states can support those providers to provide care in that way. So building on that, this slide is about payment incentivizes delivery system and practice transformation, which is really the whole point. So when we work with states and at NASHP, we try and get states to think about the vision and the goals for what they want to accomplish and how they want to improve the delivery of care. And that vision and goals help to drive the payment models that they develop. As FQHCs and other providers change how care is delivered, such as through patient-centered medical homes. They're being asked to provide additional services like care coordination that aren't traditionally billable, and they have to have a larger team-based staff with a wider range of competencies to be able to provide those, to provide care in that way. So in summary, we need to implement value-based payment models that complement how we want care to be delivered. On my next slide, so this is a framework that I borrowed and really like from the Healthcare Payment Learning and Action Network there, and they have developed 4 categories. I'm sure most people are familiar with this at this point, that build upon each other in terms of complexity and risk that providers take on. Category 1 being fee-for-service. That's low risk. It's based on volume, and there's no links to quality or care efficiency, all the way up to Category 4, which is a population-based payment that is built on quality measures and performance. And so we are, with our FQHC payment reform work, we've been working with states to think about Categories 2 through 4 in terms of payment models. Depending on the readiness for your provider types, Category 2 might be, is a good place to start and build upon because Category 4 population-based payment does require quite a bit of capacity building at the provider level. So a bit about our actual work. NASHB has a cooperative agreement with the Health Resources and Services Administration, and under that cooperative agreement, we developed the Value-Based Payment Reform Academy, which has the goal of supporting states to develop value-based alternative payment models for their FQHCs within their Medicaid programs. We started developing this in early 2016, and we selected states, and they started receiving technical assistance in May 2016, and we just wrapped up our work with them in July. The 6 states were competitively selected to participate and received a wide range of technical assistance, including individual support from NASHB staff and other national, federal, and state leaders. And then there was also opportunities for peer-to-peer learning. And so, why should states be thinking about including the FQHCs in value-based purchasing? So there's a number of reasons. The FQHCs have experience working with and engaging vulnerable populations, and often in many communities they are the only provider or the only Medicaid provider, and so they are really serving a wide range of folks in many places with a wide range of needs. They are primary care focused and prevention focused, so there's opportunities here to really impact healthcare quality for their patients and as well as long-term costs. Many FQHCs are recognized as patient-centered medical homes. As I talked about earlier, they provide a really large array of services in many instances, and so thinking about how the payment reform can support them to deliver care in an optimal way and hopefully improve quality and reduce costs. And on the other foot, why would FQHCs want to participate in value-based purchasing? And I will say that there is a lot of capacity building that is needed in many instances with FQHCs, and they need to develop their IT and data analytics capacity. Some need to work on transformation to team-based care, but despite those upfront costs and potential challenges, there is a lot of opportunity here, namely increased flexibility and opportunities to earn additional dollars can support additional workforce, practice transformation, and some of the ancillary support services like care coordination that chances are FQHCs are already providing. It can increase their capacity to catalog and use clinical data by developing those health IT platforms. Also we found that experience with value-based purchasing can help them with managed care organization contracting and developing some risk-based contracting with those entities and states with managed care. So why is payment reform for FQHCs different than the broader provider group? Well, it's because of this law that was passed in 2000, and it requires that FQHCs be reimbursed through the prospective payment system, which is basically an encounter-based payment system, or an alternative payment model. And so in many states, these FQHCs are being paid through an encounter or volume-based system, but there is opportunities here for alternative payment models as long as they meet the criteria listed on the slide. There is additional complexity than dealing with other providers because FQHCs cannot take on downside risk. As you can see on the screen, their total payments must be equivalent to or higher than what they would have received under the prospective payment system. So there are a number of states that are working on FQHC value-based payment reform across the country. In blue, you'll see the states that have payment models in development. The models that I've been tracking are Category 3 or shared savings models, such as an accountable care organization arrangement, as well as Category 4, which are more population-based payment models. And so you'll see our 6 Academy states on the screen, and then there are also 6 states that have active value-based APMs in their states. To give you an example of the range of payment models being used, so for example, Minnesota, Illinois, and Vermont, they all have FQHC networks that are engaged in, that are accountable care organizations that are engaged in shared savings arrangements with either directly with the state through a Medicaid ACO program or with a managed care plan. And then in Washington and Oregon, they've both developed interesting payment models where they have taken this prospective payment system rate for each health center, or essentially an encounter-based payment, and based on the rate itself and historical utilization, developed a per member per month prospectively paid payment to health centers to help them provide more flexible, just a more flexible payment so they can more easily provide team-based care. And then lastly, in Ohio, they are allowing FQHCs to participate in a model that's very similar to their CPC, or Comprehensive Primary Care Plus model, and they are receiving a supplemental per member per month payment for care coordination and also have the opportunity to earn shared savings. In terms of what states are thinking about that have payment models in development, I can speak to our Academy's 6 states, and they seem to all most be interested in moving towards developing a model such as in Washington or Oregon with a prospectively paid per member per month payment because of the flexibility that it does afford to providers. So what did we learn from our Academy states over the past 15 months? It was very evident that states needed to start by identifying a vision and shared goals, and then based on that vision, develop a payment model that they believe would help meet those goals. All of our state teams engaged a wide range of stakeholders when working on developing these models that was absolutely critical to the success and the progress that was made in those states. So all Academy state teams included senior leadership from Medicaid, Primary Care Association, and at least one CEO or CFO from an FQHC in the state. And some of our states also engaged Department of Health senior leadership as well, and we'll come back to that opportunities and why that was a benefit to those states in a couple of slides. Another lesson learned was definitely consider state agency bandwidth, both Medicaid and Department of Health. There's a lot of other initiatives going on, and so opportunities to align FQHC payment reform with broader initiatives can be both beneficial to the state in terms of workforce and capacity, as well as for FQHCs and other providers who might be participating in multiple demonstrations, most notably around quality measures and aligning quality measures across initiatives. The few other lessons learned that really leverage the capacity of the primary care association in your state to help assess FQHC readiness for value-based payment reform, and remember that any alternative payment model that you develop is opt-in, so not all health centers need to be ready at the time of launch, but the primary care associations can really be an ally and can help support FQHCs in developing the capacity needed to participate. And then lastly, APM development takes time. It's something you cannot rush. And so before I turn it over to my colleagues in Oklahoma, I did want to share some opportunities for health departments and why it's important for health departments to be engaged in these conversations. First of all, the focus on workforce, primary care offices, and some departments also have workforce offices, and so state FQHCs transitioning to value-based payment, really necessitates a care team model, and so looking for, making sure that they have the appropriate workforce and that the state, develops the appropriate workforce as we move to these payment models broadly. Additionally, I wanted to share a little anecdote from the state of Oregon when they developed their FQHC value-based APM back in 2013. It all started from the need to increase recruitment and retention at its state's FQHCs. They were having a really hard time holding on to good doctors and clinicians and staff. And so that was the genesis for starting to think about how can we develop a different payment model that provides more flexibility and higher quality of work for these folks and more time with patients. And so I thought that was very interesting and worth sharing. Also, often health departments house other departments that provide services that FQHCs need. And additionally, in some states, local public health departments can be FQHCs themselves, so a really need for that there. And then lastly, so much work around population health and impacting social determinants of health and upstream causes of poor health. And so it's having all of that knowledge in-house and focus within the health departments make them a really key partner. And so lastly, I'll just finish with a little bit of information on opportunities in value-based purchasing to impact social determinants of health. So this is a graphic that I like from the National Academies for Sciences, Engineering, and Medicine report that came out last year. And to move through the rest of my presentation quickly, we really think that there's an opportunity to impact social determinants of health through value-based purchasing. As I said, more flexible payment models, I really think hold the promise to helping FQHCs and other provider types be able to impact upstream issues for their clients, particularly around being able to provide care coordination and referral and support for social service agencies and other organizations that provide services that clients may need. Additionally, I think there's an opportunity for value-based purchasing to have risk stratification and tiered payments based on social determinants of health acuity of those issues for patients. And lastly, I'll just close with some information on forthcoming NASHV resources. So in a couple of days on Thursday, we have a webinar on value-based payments alternative payment methodologies for FQHC lessons from Colorado and Minnesota. That will be from 2 to 3:15 p.m. Eastern Time, and I've included the link to register if you're interested in learning more about what those two states have done. Colorado was one of our academy states and has made really great progress in developing a per member per month payment model and quality bonus model for their FQHCs that's still in development. And then you'll also hear at that webinar from a FQHC network in Minnesota that is a accountable care organization in the state's Medicaid ACO program. Also, keep on the lookout. There will be a blog coming out in early September on more lessons learned from FQHC payment reform. And then in October, we're very excited to share that there will be a toolkit which we hope will serve as help states and serve as a roadmap if you all are interested in working on this in your state. And there's my contact information. Feel free to reach out to me if you have any other questions about the Value-Based Payment Reform Academy. And with that, I'll turn it over to my colleagues in Oklahoma.
Thanks, Rachel. This is Adrienne Rowland, and I am going to just give sort of a big picture of what we're doing here on the public health side for the state of Oklahoma, and then I'm going to actually turn it over to Cassie Height from the Oklahoma Primary Care Association to get into more of the nitty-gritty and the details of our project here in Oklahoma. So really just to set the stage, see if I can do this. All right, here we go. So it's definitely a partnership model, and so one of the key things that we talked about when we were looking at this presentation was being asked of why is it important for public health, for state public health agencies to be involved and have a seat at the table, kind of the benefit on our side and the benefit on the other side. So it's really about our structure in Oklahoma because we already have...
Did we lose Adrienne?
I'm sorry? Can you hear me? Oh no, hello?
Hi Adrienne, we can hear you.
Oh, okay, great. I was like, hello? Great. All right, well, I will just jump right back in. It's hard on a webinar. You never know when you cut out or not. Apologies. Okay, well, I will just jump back in and saying with the partnership model for Oklahoma in the academy and why we're interested, kind of that big picture again, from the Health and Human Services Cabinet in Oklahoma, we're led here by state officials. The Secretary Terry Klein and Deputy Secretary Julie Cox Kane really offer that state perspective, but in addition, for us in Oklahoma, they also oversee our state public health agency here at the Oklahoma State Department of Health. So we're very closely linked and aligned with what is at the state level and making sure that the things that we're working on align closely here at the State Department of Health. In addition to that, we also do have the health workforce initiatives being staffed primarily out of the Center for Health Innovation and Effectiveness, which is housed at the State Department of Health. And then finally, we also have the Oklahoma Office of Primary Care housed in the Health Department here. So there are a lot of different areas where our focus is on payment initiatives and areas of concern and areas we feel like we could really make some benefits for health outcomes and health improvement in our state. The big plan for our state health plan is called the Oklahoma Health Improvement Plan. Our newest iteration of the OHIP plan is for 2020. Our goals and things are aligned there. So I wanted to share just kind of that's where we're coming from as our state health plan and all these things align. I also wanted to just kind of paint a picture for everybody and beyond that in 2016, the Board of Health approved a strategic plan with the overarching goal to improve population health. So with that in mind, we know that you have to align those state objectives with our Oklahoma State Department of Health. And our state public health agency sees the need to have strong health system infrastructure in place in order to achieve population-level health outcomes. In addition to looking at some of the flagship issues that we know are high-cost contributors to our state health, which were in the previous slide of tobacco use, obesity, hypertension, diabetes, behavioral health, and healthcare utilization, we also identify that the social determinants of health and in the state of health in Oklahoma, we can't improve one without improving all. So we really want to make a focus on all of these different areas. And that's really where, when we get into this partnership with our FQHCs through different projects and different partnership pieces, it is about making sure that those that are seeing the sickest or the most disadvantaged, or those that have the least access to services across our state, it is those FQHCs that are seeing them. And so we know that if we want to improve our health outcomes, then we need to work with the partners that are actually out in the communities and actually out on the ground. So of course, we're all looking at, and I think Rachel mentioned it earlier, the triple aim for healthcare. And so within OHIP, we actually have an entire area called Health Transformation Core Measures. And we talk about how we're going to achieve the triple aim for healthcare. And as we look at that, for us, we really looked at getting specific in our state in Oklahoma and trying to identify areas of focus. So we looked at population health, and one of the biggest areas we had a concern about in Oklahoma is around heart disease death, because we had seen this great uptake in heart disease deaths when it had been trending down for a very long time. So the sharp increase was a real cause of concern for us. Looking at in this time frame, and then the quality piece being really about preventable hospitalizations. But beyond that preventable hospitalizations piece, we started looking into quality measures that we could align across health systems. And then of course cost is an area that we're all looking to improve the cost of care, and looking at state purchase health expenditures to better align with what's going on not just at the federal level but also in the private market. Sorry, I took my... So the quality metric and value-based payment alignment, as you'll see within our Oklahoma Health Improvement Goal, to shift to 80% value-based by 2020. So we're really looking to transition the state insurance programs with other carriers and minimize provider loss through planned transition and invest in provider infrastructure. So we've really been trying to identify ways to find revenue and build infrastructure and really support this change. And that's been sort of the big problem in Oklahoma, is there are just not enough resources. And that's really one of the things we found in our project, this project with NASHB in Oklahoma and working with the FQHCs, is that there's not a lot of financial opportunity to provide incentive in a way that would promote this transition period. So we had to look at some other ways to do that. One way we're doing that in Oklahoma is to align things through our interagency governance structure. So within the Health and Human Services interagency governance, we also are partnered through that with Medicaid offices, our Oklahoma Department of Mental Health and Substance Abuse Services, as well as the State Department of Health and many other state agencies. So within that, we're able to really talk about how we can improve not just the quality measure side, which is a big part of it, but also how we can streamline and leverage our resources, and for the consumer side as well. But for this project, one of the big pieces of importance to recognize is that quality piece. And so what we've come up with now is to really shift and review and approve those quality measures that you see on the screen now. And this is our first phase 1, and all of these are more clinical in nature, and a lot of them are screening. So this is truly our first phase, and we are planning to do a phase 2 in the future. But what we looked at from a quality perspective from that interagency work group was to see where things were already being captured, because we didn't want to ask people to do new things. And so one of the first ways to do that, because of our partnership and infrastructure within the FQHCs and the State Department of Health leadership team really felt, because we oversee the Uncompensated Care Fund as well, which in our state is not near what we need it to be, but really starting with that as a way to build a baseline around quality metrics and identify true areas of improvement, and looking at how can we improve data and information sharing, and then really build those quality measures into not just the uncompensated care fund, which I mentioned, but also other things with our future plans around another innovation waiver for 1332, as well as some 1115 waiver down the road, which is really where we're trying to shift our movement. And so I wanted to kind of give you all a big picture of some of those draft measures and some of the OHIP initiatives so that people could see how we're aligning our state health plan with our quality measures, and then our future plans to move those quality measures into different contracts through state-based purchasing contracts, which would be our Medicaid agency, or through this first phase within our uncompensated care to the FQHCs, and then shift those toward all of our state-based purchasing. And again, I mentioned OHIP and our goals being for 2020. So we're really trying to get these things in place to have a better plan of implementation, so that we can have baseline and we can start to evaluate, and then hopefully in the short time frame be able to start seeing some of those population-based health outcomes improve. And so that's really quickly the nitty-gritty of our state perspective. And at this time I'm going to turn it over to my partner Cassidy Height over at the Oklahoma Primary Care Association.
Hi everyone. Thank you for having me. Again, my name is Cassidy Height and I work with the Oklahoma Primary Care Association. So that's the trade association representing community health centers and safety net providers in the state of Oklahoma. So I want to start by talking for just a bit about federally qualified health centers, or FQHCs, also called community health centers, CHCs, or just health centers, because I'll probably use all three over the next few minutes. So, and what it is really about health centers specifically that warrants a payment academy like the one that NASHB has hosted, and why health centers are so invested in value-based payment reform. FQHCs, like Rachel talked about earlier, are really unique in that they are private, nonprofit healthcare providers that receive grants from HRSA, the Health Resources and Services Administration, to provide primary care services in underserved areas. And they have a host of requirements, one of which is that they cannot turn away a patient based on their ability to pay. Depending on the health center, though, their federal grant likely makes up only a small share of their total operating revenue. In Oklahoma, health centers' federal grants make up less than a third of their total revenues, with another whole third coming in from Medicaid. So while it's important that health centers have grants to ensure that they can continue providing care to the uninsured, which constitute 1 in 3 health center patients here in Oklahoma, Medicaid is an equally important payer for health centers. In fact, Medicaid is a huge chunk of all of see if I'm on the right side here. Yeah. It's a huge chunk of all the payments that health centers receive for their actual services, partly because such a large share of health center patients rely on Medicaid, and partly because of the payment structure that health centers currently receive under Medicaid. So like Rachel alluded to, health centers are, or said rather, health centers are essentially reimbursed based on their cost. They were up until about 2000 when the Prospective Payment System, or PPS, was introduced under the Medicare, Medicaid, and S-CHIP Benefits Improvement and Protection Act, BIPA. So the PPS is calculated differently in different states, and states all have different methods for increasing or changing it, but the PPS is basically a payment floor that pays health centers their average cost per encounter. And the PPS is important because health centers are very concerned with preserving it, even as we're moving towards value-based care, even as we're testing the waters. The PPS, even though it's still cost-based, ensures that health centers are at least paid their average cost per visit. And the idea behind the PPS was to protect the investment that the federal government was already making in health centers in the form of those grants. So rather than see health centers fail to make ends meet on one end because their Medicaid reimbursement was too low and have to make up for it by either closing down sites in areas that we already know are underserved, or by increasing grant funding, or something else entirely, the PPS was introduced to try and protect health center revenue. So why do health centers want to move to value-based payment? Because of the way that the PPS works currently, health centers are paid a predetermined amount every time that they have a qualifying encounter. That phrase is important because when we think about the move to value-based care, we think more and more about the different types of health interventions that can address patient outcomes. So Rachel talked a little bit earlier about social determinants of health. More and more we're thinking about the role that that plays in a patient's health care and of ways that we can improve patient care outside of the health center, whether that's making sure that your asthmatic patient has a bed to sleep on so they aren't continually readmitted to the emergency room, whether that's calling and checking on patients who haven't picked up their prescriptions. We know that there are other ways that we can take care of patients that don't mesh with the traditional kind of conveyor belt form of healthcare that where we're strictly concerned with the volume of patients' encounters. But health centers have been a part of patient-centered care, not just patient-centered medical homes, but truly patient-centered comprehensive health care since they came about in the 60s. The first health centers in Boston and Mississippi were really concerned with addressing food insecurity and poverty and home conditions. And health centers are still doing this work today, but a lot of them aren't getting paid for it or reimbursed for it because it isn't technically a qualifying encounter or a PPS billable. So what we've been working with with OSDH, or the Oklahoma State Department of Health and the Oklahoma Healthcare Authority, along with NASHB and our other partners, is working on a system that allows health centers to opt in to a per member per month arrangement, where health centers are paid a per member rate every month for the patients that we can attribute to that health center, patients where that health center is their medical home. The idea is that health centers can demonstrate that they can provide the same or better level of care without the restriction that they be paid solely on those qualifying encounters or visits. Though our state budget is rather strained right now, like Adrienne mentioned, we are going to continue to work with our State Department of Health and Healthcare Authority to look at ways that we can share in the savings produced to the system. So ideally we would have as Colorado has developed, as other states like Washington have developed, a per member per month, but with a payment we sometimes refer to as a wedge payment that is a care management or an additional incentive payment that health centers could receive for achieving superior quality results. Given the restraints in our current budget environment here in Oklahoma, we're working towards a shared savings system so we stay at least budget neutral for the state. So I mentioned that the budget has restricted some of the scope of our project, but our state also elected not to expand Medicaid. I believe we're the only state in NASHB's Payment Academy that didn't expand. So whereas Medicaid represents about half of health centers' patients nationally, it's only about a third here in Oklahoma. And health centers that have a higher percentage of uninsured patients who aren't on Medicaid have a higher rate of uncompensated costs from those patients. And it means that margins are tight at health centers, and it also means that health centers are a little hesitant about venturing out to alternative payment models. So because of all of that, the need to partner with state agencies was obvious to us. We're really thankful for the existing relationships we have. We couldn't have started this process without having relationships with our Healthcare Authority and Department of Health in place. In fact, our NASHB team has had quite a few staff changes throughout the course of the project. Our state's Deputy Medicaid Director was on the team when she was promoted to State Medicaid Director. Did I say she was Deputy and now she's Director? That's how it went. And so having her support on this has been huge. I don't think Adrienne or I were on the start from the beginning, but because of the institutional partnerships and our institutional shared commitments to moving forward on value-based payment, it's what enabled us to progress together. So the Academy also really helped formalize the relationships that we had. So we've met several times now with the state health agencies about where to go from here on value-based initiatives. And we're talking about the need for good data and analytics in the context of value-based payment. So we're emphasizing the need to be sharing data and putting together MOUs to start doing that. Just talking about health centers' role in the healthcare delivery system here in Oklahoma has been really a blessing for us because it means that we've strengthened our relationship with OSDH and the Healthcare Authority. And now we have a real, true invested advocates in both of those areas. So again, we were really fortunate to be selected to participate in the Academy, and it was really the impetus that we needed here at the Primary Care Association with community health centers to move forward on value-based care, and we're really looking forward to continuing to work together. Well, that's it. So with that, I'll turn it back to Mary Ann.
Thank you, Adrienne and Cassidy. That was really terrific information, and it's so valuable to be able to share that kind of information with our stakeholders and our partners on the Integration Forum. So now we can open up the lines to have a discussion, and if everyone would press *1, you can unmute your phone line, or you can submit your questions through the chat box that's located on your screen. For me, it's on the lower left side. I don't know if it's that way for others, but if you want to submit your questions now, that would be great. Otherwise, anyone have a question they want to ask, and we can ask the operator to work with us. Thank you.
Thank you. Once again, ladies and gentlemen, if you do have a question, please signal by pressing *1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Again, press *1 to ask a question. We'll pause for just a moment to allow everyone the opportunity to signal for questions. Once again, ladies and gentlemen, if you do have a question, please press *1 at this time.
Well, I have a question
at this time.
I have a question for either one of you. So can the alternative payment models that were designed for the hospital-based outpatient clinics be adapted for implementation at any FQHC or the regional health clinics, or the rural health clinics, rather?
Hi, Marianne. This is Rachel. I can answer that briefly. So NASHP is aware of one state that has taken that approach in implementing an alternative payment methodology for its FQHCs, and that is New York. But I think that it has been, from what we understand, it has been very complicated for health centers to make that transition. So I don't think many health centers have adopted that model, but it is something that some states are thinking about how that could be used, how outpatient hospital billing structures could be used. But I don't have. We could certainly refer you to talk with New York, but I don't have any other information on that.
Thanks, Rachel. Anyone else have a call? Have a question?
I see one on the online chat box that I can answer unless we'll wait for those.
Okay. I do not see the question, so if you want to read it, that would be great.
Sure, absolutely. So I see a question from Ted that says, how have the attribution lists that you've received from payers matched up with the actual patients enrolled in your FQHC practices? Now, we were really fortunate to have a couple great project participants from the health centers, including a couple CFOs from the health centers who really got down into the details and worked with the Healthcare Authority here to make sure that their attribution lists lined up. What we saw from the Healthcare Authority, and I should mention that because Oklahoma, we are not a managed care state, the only payer we're dealing with for this APM right now is the state Medicaid agency. We were really surprised at how well the attribution list lined up with what we received from the Healthcare Authority. And if you're interested in looking delving a little more into how exactly we went about that process, I could explain it a little bit, or I could pass on some folks who were involved with that. But of course, the attribution list is critical when you're moving to a PMPM, and we're still working with how we're going to request changes in scope to make sure that those lists are up to date when we start a new site or add a new service or have a large influx of patients. But again, I wish I could answer that in a little more detail, but if you're looking for more, I can find an answer for you.
Thank you very much. Any other questions? Well, I guess we could move on if we don't have any more questions. Well, I have one more that I would like to ask, because I think it's important for, in particular, our state health officials and our public health partners out there that may be interested in hearing a little bit more about the integration of work relative to the social determinants of health within these payment models. And you referenced it, Rachel, early in your presentation. I wonder if you could just let us know, from your perspective at NASHB, the degree to success that you think, if we were on a maturity scale of working toward both assessing and for the payers to become more involved in working with their public health departments relative to the determinants of health, where would you say we are on that maturity scale?
So that's a really good question, Marianne. I think that it definitely varies by state. I don't want it to seem like a cop-out, but there are, as you know, there's 50 different states and, and the District of Columbia and our territories, and, they all have different relationships in that area. I think that it is something that states are definitely thinking about. We're starting to see in accountable care organization models in state Medicaid programs, there's a larger scope of services that are being included in the total cost of care calculation, and also, and starting to think about upstream causes of health. There are some states like the District of Columbia, who is in our Value-Based Payment Reform Academy, who's very focused on how they can start to measure the needs of patients at its different FQHCs, and how and then what that data can be used for, and how it can be and how it can impact policy. And then, as we see states start to go to capitation, or for FQHCs, a per member per month payment methodology. Certainly some states are thinking about that, and it really opens up while it doesn't directly incentivize health centers to think about the social determinants of health, it's something that health centers are thinking about every day, just because of the complexity and the needs of their patient population. And so they are, a lot of them that tend to be larger and have a larger capacity for IT and data analytics, are really thinking about and interested in a per member per month model, especially, at least from what we're hearing in our academy states, because of the flexibility it allows for them to really try and meet their patients' needs where they are. So I would say that it's definitely on states' minds, and time will tell how it impacts payment models, but it's definitely on the minds, and we're moving in that direction.
Thanks so much. That's wonderful to hear that we are aware of some states that are moving in this direction, and we're wondering how things are going. And anybody that may be on the call that has some detailed information, please feel free to reach out to folks here at ASTO or anyone else on the call. Now I'd like to turn it over to an opportunity for some of our participants to share what's happening, and if there are any new resources or upcoming events happening. And I know that we have Lisa from NCFL who has something to share. Lisa? Lisa?
Oh, well, I don't know about that. Yeah.
Pardon the
So those
interruption.
that
All
are,
lines are now open and interactive. If Lisa is on the line, your line is now open. All others, please use your mute button when not speaking. Thank you.
Two of them you can, I believe, it's a record radio button. Like these right here, radio buttons.
well, I'm wondering if we're having some technical difficulties.
Radio button, like I would say time in or time out.
So while we wait for Lisa, is there anyone else on the line that would like to share what's coming up in some of your organizations and your agencies?
I thought they'd do that for two reasons. Maybe to see if the person was lying with, oh, I can't.
Once again, ladies and gentlemen, all lines are open and interactive at this time.
Yeah.
How many times this person clocked in?
I'm wondering if we are not getting through to the person that doesn't seem to be connecting. Does anyone else have something they would like to share? Well, hearing none, I just want to thank our speakers, Rachel, Adrienne, and Cassidy. The information you provided today on the value-based payment has been really informative, and I want to thank you very much. So for those of you on the line, please email the integration forum at asto.org. You can see that information on the slide, or I believe that Anna Bartels has sent it as an IM to most of us here on the webinar. But if you want to share any resources or ask any questions of the ASTO team or the folks that were on the call today, we invite all participation for members, and please share the news about Integration Forum. And have a wonderful afternoon, everyone, and enjoy the eclipse. Bye-bye.